Let me start by recognizing that although I'm speaking for myself today, but the work that I'll be sharing with you over the next 40 minutes or so largely represents a group's work. And those people who'll be working with me both in South Asia, in Pakistan in particular, East Africa, and also at my Center for Global Child Health here in Toronto. To them, really, I owe a tremendous debt of gratitude for decades of work, which has led to some of the thought processes that I'll share with you today. Why should we look at the past? What is it that the past tells us in terms of the global context of challenges and their potential solutions? Well, an important reasoning for that is that if we don't look at the past, we will not be able to overcome some of the mistakes that we have made through the decades, or if not more, in terms of global policies, strategies, failures, and also learning from those in terms of doing things better. Well, the world has changed enormously, and particularly in the last few months. But it doesn't take long to go back to see how the world was truly different just a quarter of a century ago. This image from the UN General Assembly session, the Millennium Summit, which was held in September 2000, is a remarkable image. You not only see the leaders of all the high-income global powers standing together side by side. President Clinton standing close to President Putin from Russia, from the leaders of the European Union and China. You see also Fidel Castro standing amongst many of these global leaders, Yasser Arafat and Ehud Barak from Israel and Palestine standing close to each other. And what brought these major leaders, over 140 of them, to New York at that time? Well, they got together because this was the first UN Millennium Summit, particularly focused on what could be done for the most vulnerable, poor populations of the world. And it was one of the bases for the development of the Millennium Development Goals, of which a major goal was to reduce child mortality by 2/3 by the year 2015, using some of the benchmarks of 1990 as a base, because we did not have exact figures, and maternal mortality by 3/4 by the year 2015. And that was the global compact, the covenant that all these global leaders signed in terms of making a difference. Well, time flew, and as you are aware, right after that Millennium Summit in 2000, unfortunately, we had 9/11, and the world came to a standstill. And nothing really happened for a couple of years because the world was lost in a turmoil of unspeakable proportions. And then in early 2003, I received an invitation to join a group in a scenic setting of Lake Como in Bellagio. And I can never really understand why people want to meet in some of the most beautiful places of the world to discuss some of the world's ugliest problems. And I almost didn't go. But I was encouraged to go because of our work that had begun at that time on looking at community strategies for children and newborns in particular, and to join this so-called Global Child Survival Group in Bellagio, Italy, to consider what could be done for children of the world. And there are some of these global heroes who have been my colleagues over the last quarter of a century who worked to produce the first child survival series. Indeed, the first series that the Lancet ever did on considering some of these global challenges. What did we assemble to consider? We did one of the first determinations of the global burden of child mortality, its distribution, numbers, and produced this infographic that is widely regarded as one of the most influential infographics in the world, because it not only highlighted where these deaths were, it also underscored how they were concentrated according to population density. So South Asia appears as a blur, even though the rates of child mortality might be higher in Africa. But these 10 million children who were dying every year was a sobering number. We also produced at the same time a set of solutions that we thought could potentially address this. And we said very clearly that we knew enough at that time from evidence-informed interventions maybe not sufficient systematic reviews at that time, but we could do something to prevent a large proportion of these deaths, almost 2/3. And this is one of the first demonstrations, ladies and gentlemen, as to how a body of scholarship from academic centers, from professionals, could influence the world, because this turned out to be one of the most influential bodies of work, because this woke people up. It woke people up to action, woke governments up to action. It also encouraged them to see what they could make a difference with. And now when I look back as to what happened between that time and 2015, when the Millennium's goals finished, it was nothing short of remarkable. So for child mortality, by 2015, we were able to bring the number of deaths down to an estimated 12 million in 1990, 10 million in 2000, to just under 6 million. And if you take the global increase in population into account, the world actually met Millennium Goal 4 for child survival. And this could only have happened through a spirit of collaboration, cooperation, and joint work. But this was not perfect. And in many of these stories, there are always blind spots. So as we got wiser towards the end of the MDGs, we realized that there were indeed things that we had missed and not really sufficiently taken into account. So what were these major blind spots? The first was that this progress wasn't equal. Although we had reduced the number of child deaths overall, but you disaggregated the data and you looked at which countries had produced that change, you saw that bulk of the change was through big countries like China, some countries in the Middle East, Brazil, and parts of Latin America and Southeast Asia. And it was by no means universal, because you see Africa still lagged behind and South Asia's progress was less than optimal. Well, the person who recognized this and spoke about this almost within weeks of his taking office was no less than Tony Lake, the head of UNICEF, who in 2010 made this remarkable observation almost immediately after taking office. He said that these national statistics or successes hide behind them terrible moral and practical failures and ugly realities of how people have been left behind, because they live in either rural populations or in poor communities, or they're left behind on the basis of disability, their ethnicity, etc. And a lot of people didn't quite understand this. She said, we have made progress. Why are you dissing it? And he made a very important observation that in that progress, not everybody had moved at the same pace. Let me illustrate that with this cartoon, which shows you on the x-axis countries that had reduced child mortality, under 5 mortality as you see it, by either seeing a reduction in inequality or not an optimal reduction in inequality. And here on this y-axis are those countries that actually saw an increase in inequality, despite the fact that they reduced child mortality. And here is the ideal group of countries in green, where they not only reduced child mortality, but also reduced it proportionately across all groups. So a lot of my students don't quite understand, how can this happen? How can you reduce mortality and yet see widening of inequality? Well, it's very simple to understand this, because the fruits and benefits of interventions don't necessarily pass to those who need it most. Many a time, just like the GDP per capita, income of a country can be disproportionately pulled by the top 1% of billionaires. Similarly, mortality reduction can be driven by those who receive interventions first, live in well-resourced urban populations, have access to services, are educated, and therefore empowered. So not all benefits accrue to people equally. And we saw this at the end of the Millennium Development Goals very starkly in the difference between countries. So these serial Manhattan plots, which show you median national coverages of selected interventions around the end of the Millennium Development Goals, each one of these dots, ladies and gentlemen, represents a country. And as you can see, for many of these interventions highlighted here, whether they are treatment of people with HIV or vaccinations for neonatal tetanus, skilled birth attendants, there is a tremendous difference in coverage, with some countries actually falling through the cracks and others achieving close to 100% coverage. And you see this across the board. Maybe less so for childhood immunizations, which are largely a vertical program, but certainly for things that relate to nutrition and things that relate to many of the social determinants of health, water sanitation, and hygiene. We also missed two other important things in the Millennium Development Goals. And those were the two extremes of childhood. We looked at child mortality as an aggregate target. And on child mortality, we did well. You can see maternal mortality going down, child mortality going down reasonably by the end of the MDGs. But look at where newborn mortality was. And this was because there wasn't the recognition at the time when these goals were crafted that almost half of all child deaths are in the newborn period. And not just in the newborn period of the first 28 days. Actually, a bulk of these deaths are very early. So if you just take the first day of life, the critical window of risk, most of the direct maternal observed obstetric deaths due to hemorrhage, obstructed labor, uterine rupture, they are largely concentrated in that space. Around half of all stillbirths are in that first day of life, 24 hours in and around childbirth. And about a third of all neonatal deaths are in that period. So that happiest day in the life of many people, the day of birth, is also sadly the saddest day in the life for some who don't make it. So we miss that early period of child health as a critical window for which we did not set any targets at that time because there wasn't the awareness. A very important lesson of the eye not seeing what the mind does not know. There were very sensible people in the room when the MDG targets were being set, but yet this point was not appreciated. The other point that wasn't appreciated fast enough, and we only realized that towards the end of the MDGs, was that children are not always children under 5, that there are school-age children and there are adolescents. So I was a member of the UN Secretary General's Independent Expert Review Group for MDGs, and we made this observation in 2013 that adolescents were just absent from the equation, that we were not asked to look at them. There was no discussion. There was no target set for them. And it was partly because many of these young adolescents who were basically adolescent mothers were children having children. And it was disproportionately clustered amongst the poorest quintiles of the population. So these are also children by definition who have grown up too fast and have also been burdened with the disadvantages of early motherhood and the interruption of their education and development very early. So this was missed in the MDGs. And then we also discovered that there was something between the newborn period and the adolescence, and this was the missing middle, school-age children. And it actually took a pandemic for us to realize that they were important because of the burden that this group had with many of the COVID-related school closures. So the two things that we recognized was that not only was this group important in terms of numbers, but also that there was a significant mortality clustered in that age group. If you take school-age children, 5 to 9, and young adolescents, between them are close to around 1 million deaths that happen every year. And these were not recognized, and they hadn't changed very much over a period of time. And as I mentioned, it took COVID to tell us how important mental health was in this age group, because we saw that there were increase in anxiety, increase in mental health disorders, depression in this age group was close to around 30% overall. Now, why is this early life period? Why is childhood, early childhood in particular, important? Well, it's important, ladies and gentlemen, because early adversity matters. And it matters not just to immediate outcomes in that time period, but it matters because of the consequences across the life course. Now, we look at many of those consequences through the lens of deprivation. And the most common measure of deprivation is living in poverty. And in many populations, poverty has a child's face. But I want you to be aware of the nature of poverty that is more than just income or assets or the money that you have in your pocket. And nobody's explained that much better than Mother Teresa when she said, the greatest form of poverty is not just being hungry, naked, homeless. It is about the poverty of being unwanted, uncared for, and unloved. And this early lack of nurturing care, the proper environment, growing up in adverse circumstances, whether it's domestic violence, whether it is conflict, whether it's living in a household with drug abusers, or more egregious forms of childhood maltreatment, those things have consequences that are across a lifetime. We reviewed this recently, in terms of seeing what is the biology behind that early exposure. And to some of you in the audience who are interested in a deeper dive, please read this review that we put together, looking at not only the physiological mechanism, but the biology behind our understanding as to how that early adverse exposure, in terms of timing and sensitive periods, alters your lifelong trajectory for growth and development in a way that is very difficult to reverse. And hence the importance of that critical early period in terms of targeting and interventions. So when you put it all together, ladies and gentlemen, this early adversity that families, children are exposed to around these sensitive time periods, not only are windows of opportunity for interventions, but they also tell you how they impact the physiology, the microbiome, the proteomics, and metabolomics in the context of lifelong development. So we now know that developmental trajectories and long-term outcomes, whether they are mental health, whether they are non-communicable diseases, cardiovascular disease, even cancers, are influenced to a large extent by that early adverse exposure. Now, where is the evidence that this really matters in the global context? And I've given you some anecdotal evidence of why inequity matters, but does this really represent a global challenge as we speak today? Of course it does. We looked at this as part of a recent Lancet series that I shall share with you shortly, where we looked at the life course across the first 2 decades of life. And we assessed in 95 countries a range of outcomes, starting with child mortality differentials by socioeconomic gradients, quantified and measured in a standardized, comparable manner across these countries. And you can see that the poorest regions of the world, Africa, really stand out by this very wide differential that we have between the wealth deciles. Now, this is not quintiles, this is deciles or 10%. And you can see the difference between the poorest or the ultra poor is as wide as you can see observed on this particular slide. And in all regions, notably in South Asia, notably in East Africa, Southeast Asia, these things are quite remarkable. And they're not just for mortality. When you look at a range of other outcomes, and here in this particular graphic, we have shown this, and I'm not entirely sure that you can see this in its entirety for childhood, for stunting prevalence in children under 5, lack of child development, and even things that are consequential across the life course like teenage motherhood. Just look at the gaps between the rich and the poor. And this can influence adult human capital. We were interested to see how can this influence what happens going forward. And for things like attained schooling, intelligence quotient, and also eventual height, which I don't show on this slide. Cesar Victoria and team were able to show enormous differentials between the rich and the poor, measured by this one measure, but this is not the only measure of the difference between various subgroups. So I want to now change gears and talk about other contextual factors that we don't often talk about in the context of child mortality and child health. I've talked about poverty. We've talked about living in poor populations. So colleagues of mine in Stanford produced this seminal paper that I would call Subnational Variations in Child Mortality in Africa. They were looking at what are the lessons to be learned from various countries and these surveys in terms of how child mortality has changed in Africa over time. And their interest was to look at disease interventions, and they saw something very remarkable. And they looked at these data by surveys associated with geospatial data, location. They saw in many instances that the risks or the hotspots for where there were opportunities for interventions and also clustering of mortality often crossed administrative boundaries of countries. So they represented perhaps some ecological factors that were not restricted to one country versus another because it affected entire regions and neighborhoods. And the various things that are looked at through this very interesting body of work in 28 sub-Saharan African countries over time between 1980 and 2010, explaining about 3/4 of all the variation in mortality, showed that around 23% of all eligible children in these countries lived in these mortality hotspots. So this was not small, about 1/4 of all these children. And what were the three major drivers that they were able to find? Change in local temperature, malaria, and a recent history of conflict. So if there were ever naysayers in terms of climate change, deniers, or people who think it doesn't matter, this study was a good example of why it mattered, and not only climate change, but climate change in the context of conflict. So these variations also stimulated us to do some work that I will share shortly to try and quantify this relationship a little better. But first, a word on climate change. I mean, people think climate change really affects susceptible populations, elderly, vulnerable, because that's what generally observed in high income settings. But climate change, again, has a child's face. And as was shown in this recent UNICEF report, the number of children who are exposed to at least two of overlapping climate risk factors exceeds 2 billion. And once you reach to multiple overlapping climate and environmental hazards, you still are dealing 100 to 300 million children worldwide who are exposed to these risks. From my own country of origin, where I do a lot of my work in Pakistan, in 2022, with these biblical floods, which displaced and affected close to around 30 million population, if you look at what happened in that early period, the people affected were women and children. Close to around 600,000 pregnant women had no access to care because all the hospitals were washed away. A third of all deaths that occurred in the first week or 10 days of this flood disaster were children. And of course, with schools being destroyed, the country has not been able to recover from the economic shock of that 2022 floods. So far, it's been a huge battle to try and even raise a fraction of the $40 billion that were lost in that 1 to 1.5 months of cataclysmic floods. But climate change not just impacts mortality, does not just impact displacement. Climate change has other effects as well. And I just want to show you something that I've learned myself as I've begun my work in this area, a new terminology called solastalgia, or climate anxiety. And if you look at how young people are affected by climate anxiety, the proportions are striking across the board in high income as well as in low income countries, India, Nigeria, and others. About a quarter of all people impacted amongst young children and adolescents are those who can be categorized as extremely worried about their future or very worried about their future. And this is easy to understand because they know that their future is being lost as we speak, especially as we roll back our agreements with the Paris Climate Summit. If we begin to deny everything that exists right in our face, right with the evidence that we have had in California, this becomes quite challenging for young people. And it's not just climate change alone. Remember that climate change is a threat multiplier. And in many parts of the world, climate change, conflict, displacement go hand in hand, with climate change also being a driver for conflict in many settings. People fight for resources. How many of the people in the audience know that the entire Darfur conflict in Sudan was around a fight for water resources? That the original Syrian conflict that started over a decade ago also started because of conflicts around water resources and sharing. So these things are important to underscore. And one of the main reasons why I set up and founded a consortium to look at these contextual factors in greater depth. The branch consortium was set up to bridge research and action in conflict settings for the health of women and children. And it represented some of the topmost universities in the world because we brought them together, the Harvards, the Hopkins, Stanfords, London School of Hygiene and Tropical Medicine. And I was very honored to be able to coordinate and lead that from Toronto. And one of the first bodies of work that we did was to try and quantify child mortality using some modern methods, again with our friends in Stanford in Africa, to see the numbers because there was not enough clarity around what numbers were there. And our work showed very clearly that this was not only significant, but that this resulted in close to around 11 million deaths of women and children in Africa due to direct and indirect effects of conflict. So we're not dealing with less than 1%. This is quite a major contributor in some regions to deaths of women and children. And these effects of conflict on mortality for children and mothers also compounds over time as health systems get disrupted. You can see that with the severity of and longevity of these conflicts over years, the impact on mortality because of disruption in health systems also increases gradually. But the most egregious and the most deplorable form of impact of conflict in recent years has been the deliberate targeting of children and children's health facilities. So not only when the children's hospital in Kiev gets targeted, but it's also what we have seen in Gaza. When we quantified this recently in terms of how many children had been killed in the conflict in Gaza in the last 15 months or so, and compared it with all urban conflicts in recent memory, including going back to the time of the Second World War with large sieges, this is just through the roof. The proportion of child deaths in Gaza because of the armaments used and the concentration of people and civilian populations was just unheard of. But Gaza was in our face. We were hearing about it every day. We were seeing it in front of our eyes. And as we speak, the unseen conflict and unspoken about conflict that impacts women and children at scale, and maybe not with deaths, but with forms of violence, gender-based violence, rape, torture, sexual harassment, are Sudan. And in Sudan, we recognize that half of all displaced children represent half of all displaced people are children under 18. And about 2.8 million of those are children under 5. And I want to close this part of my presentation by underscoring what I just told you about that early exposure to adversity. This early exposure to adversity, direct or indirect, witnessing conflict, has not only a lifetime impact in terms of growth and development, failure of coping mechanisms, but can also be transferred to the next generation in a quasi-genetic fashion. So children who are inured and exposed to violence are also perpetrators of violence in the future. And therefore, measures and adaptation, resilience measures have to be put very early to prevent the damage that you can see from that early exposure to violence. Now, I want to change gears now and talk about solutions. So how can we make a difference? In this broken world, in this doom and gloom scenario around us, are there any glimmers of hope that interventions can make a difference? Can we replicate what we did in the Millennium Goal period? So yes, I mean, there are some strategies that can make a difference. And one of those relates to how can we reduce the inequities that I was talking about? And can we do this through strategies that directly target the poorest of the poor? And here comes the role of community health workers, something that I've worked on for the last 30 years, trying to work with these outreach workers to reach those who cannot be reached in hospitals or through healthcare professionals of the kind that represent physicians or highly trained individuals. A big body of our interest was to try and see if we could reduce neonatal mortality. So we looked at the global evidence of how community health workers, and not only did we look at the work of others, we actually implemented several cluster randomized trials in this area. And the big question was, can this be done by public sector programs? So if you look at the overall evidence of neonatal mortality reduction through large-scale government programs, as opposed to locally funded research-based staff, yes, research-based staff at times can produce greater impact because you have the power to hire and fire. But government programs also reduce mortality. And I would take 14% reduction in neonatal mortality at scale in government programs anytime. And they also impact maternal health. So if you just take institutional deliveries, facility-based deliveries as a marker, you see the opposite figure. You see government sector programs doing much better than private sector programs because they are able to refer to public sector facilities and have greater contact with them. So one big question that emerged from a lot of this body of work over the last several decades is, can you implement something like this in real health systems? Can you do this at scale? And can you do this in some of the most difficult geographies that we are talking about? And yes, we can. And I'm very pleased to share with you results from a very large body of work that we've recently concluded in Pakistan, looking at this New Hope project. Around 12 districts of the highest mortality burden in the country, representing a population of 17 million people, with about 10 million which are covered by the government's Community Health Workers Program. And the targeted population was basically women and children and newborns at risk of excess mortality. Now, because this was a real life study and this has taken us almost 8 years to finish, we had to work through the reality of living through the current times. So these were the very districts also that were affected by the floods that I talked to you about in 2022. So what you're going to see is, irrespective of all of those natural disasters, what were we able to achieve and see? So first point is that we were able to see that the government program, and we didn't implement it, the government did. We supported them through adequate training and handholding at times, that over time, over within this 5-year period, the coverage of effective interventions increased significantly across the entire region. These are various districts of where the project was implemented, and the change was not only significant, was quite remarkable, reaching for many proportions of around 70-75% coverage. We also saw a commensurate reduction in mortality. And in terms of numbers, the observed mortality reduction for newborns, for perinatal mortality, stillbirths, is all around 30%, far higher than what we had anticipated and far higher than what the systematic reviews showed. And for the same time period, if you look at the secular trends in other districts and what we saw in these particular districts, the proportions are about 2 to 3 folds greater mortality. And you probably don't need to see the numbers. Let me show you how you could visually see the impact in some of these geographies. So here is the district Badin in Sindh, very high mortality clustered around certain regions, and there were reasons for this. I mean, lack of access to facilities and also topography, geography. We saw what happened after the floods. You can see an overall increase in that period. And by the end of 2024, you can also see the change in that period. Well, this was Sindh. You go to Punjab and the district of Muzaffargarh, and you see a similar clustering of mortality at a sub-district level, particularly around areas where the population was clustered and some of the health facilities were dysfunctional. You see also how it changed over time and how, by the end of this project, many of these areas which are high pockets of mortality had become better. We obviously did not influence everything, and you can still see high pockets of mortality because the government programs could not reach many people, but also a very interesting observation. So when you look at who benefited most, even in these very poor districts, the relative rich in these poor districts benefited more. So you can see that in this particular coverage change over time, the change in coverage for most interventions, perhaps with the exception of skilled birth attendants and facility births, were the highest in the relatively rich. And this is the reason why you have to actively target the most impoverished, the most marginalized in many of these areas through active interventions. Now, this obviously was a project in which flood-affected populations were seen, and in 2022, we saw that in Sindh. And we were able to also test some innovations through the power of working to reach the poorest of the poor through community health workers. So this cluster randomized trial of a very simple intervention. Could you, in a place where health facilities were less than optimally functional, there were not enough health professionals, could you use community health workers to get interventions to families and communities that they could use themselves or take themselves to health facilities when needed? So this was a distribution program of clean delivery kits in both intervention and control areas, with some notable differences between those kits, with the intervention areas receiving interventions to address cord care through chlorhexidine and also skin care to prevent many of the skin infections and breakdowns that happen in very hot environments. So these community health workers were mobile. They were able to reach out people and distribute what is a very simple intervention to address hygiene, hand hygiene, as well as the hygiene, skin hygiene of these babies. And although, this was relatively small and rapid and did not show a massive reduction in neonatal mortality, but you see that the mortality rates in the intervention areas were lower. And some of the effects on stillbirths and perinatal mortality were indeed significant because many of these individuals are able to reach to birthing facilities with these clean birth kits and able to address them. Now, this was floods and not necessarily an insecure area. So one big question that I'm asked is, can these things be done in fragile and conflict settings where you also have an element of insecurity? And I can answer that question now with great confidence, say yes. You can work through these community-based interventions. And one of the areas that we have worked in is really on integration of maternal child health and immunization strategies in conflict and insecure settings. And one of the reasons to do that is because many of the children in these settings are unimmunized. And we know that that extends to almost a fifth of all children. The challenge that we have is we don't know where that fifth child is. It's not standing next to the fourth child. So you have to reach to the most marginalized populations in an effort to reach those children because they are not easily identified and they're not geotagged in terms of reaching them individually. So in this one project, we worked with community members, elders, community health workers, government programs, and integrated a maternal child health strategy with the vaccination outreach program that already existed. So rather than have these programs work vertically, we integrated them in these settings to try and see what could be done in these very high-risk areas in terms of improving health, nutrition, and immunization interventions. Amra Khan in my group has been working on this, and she's just about to finish her PhD looking at what can be done in these strategies. So you can read some of these data that have been published in relation to this project. And I'm only going to show you a couple of outcome slides just to show you what difference can be made in terms of outcomes in such settings. So if you look at when we began, and these are the three provinces where these interventions were done, Balochistan, very high-risk conflict, Khyber Pakhtunkhwa, the north, and Karachi insecure areas. And you see that in many of these areas, particularly in Balochistan, the difference between the various wealth quintiles quite significant, quite large. And by the end of this body of work, which was done through these community health workers and outreach workers, within 18 months, see what happens. I mean, you can reduce these disparities. And in Karachi, certainly almost the disappearance of any vaccine coverage data in terms of unimmunized children in that particular region. So let me now conclude in the final session of this presentation by asking ourselves the question, how can we build a future of hope? And how can we do this in the current context of adversity, challenges, etc.? And we recognize that we have a new global target that was set in 2015 around sustainable development. And these sustainable development goals were coined for all the countries in the world. They were interrupted by COVID. They are just as important for Canada. And they represent not just the two goals that we had in the millennium period, but these 17 goals are interrelated. And many of them are health and health-related goals. There is only one goal for health, goal 3. But you also have linked goals for nutrition, for education, for gender equality, water sanitation, hygiene, reduction of inequalities, and also importantly, sustainable development. To see how we could do this, we brought the same group, some of them much older, but many fresh young faces into Bellagio, some 20 years after the first time that we had met there. And this group, which again represented many of the leading centers of the world, including the countdown process, produced these 4 papers that I would encourage all of you to read. It's called the Lancet 0 to 20 series or Optimizing Child Health series. These papers were produced during the later stage of the COVID period, and they relate to not only how we can do things better, but how they can be done within the context of health systems and lead to change in the future. They talk about the early adversity that I've spoken to you about, how these exposures in the early life period can be counterbalanced by interventions all targeted towards those sensitive periods. The series talks about how we should bring in other sectors and not just work within health sector, but the importance of services, communities, social protection, socio-political environment, and climate and environment change all linked together to address this early nurturing care, which has 5 elements across those first 2 decades of life of optimizing health, optimizing nutrition, provision of safety and security, a nurturant early learning environment, and also the strength of family relationships. You bring these all together, and we made 8 recommendations to promote human capital growth. Firstly, we must begin to look at this in all countries, not just in low and middle income countries, but in Canada, to look at children through the lens of the life course, which meant that you eliminate these age-based silos. And in many countries, not just have an under-5 child health program and then you forget about them, but look at children as a continuity in the first 2 decades of life. And that would also allow you to build appropriate interventions that then link to each other. So children under 5 who have interventions largely around the health sector should be linked then to school-age children programs, both within schools and also within the health system, and linking to what adolescents need themselves. We also talked about the importance of implementation science and learning in complex adaptive systems and country-level ownership. As the ground realities are emerging with the depreciation that we have worldwide in development assistance, countries have to learn to stand on their feet, and which means that countries have to find a way to link social services, health, and education, and provide it the leadership themselves. We need that enabling environment with national policies, regional oversight, and also children connected to the family supportive and community environment that we have talked about. And we've talked about how we need to bring climate and environment in terms of the interventions that we need to place within the health sector. It cannot be delinked from the agenda that we have on climate change. And of course, we need money. And I know we are not going to get this. And that means also that countries have got to learn how to stand on their feet. And for the very ultra-poor countries, we need to find mechanisms to support them. And we are now, ladies and gentlemen, talking about all children. We're not talking about just children in marginalized populations. The equity principles indicate that we tackle the needs of all children, and we find mechanisms to address the needs of children in greatest need through innovations. So my final thoughts are that despite global progress, we still have a challenge of inequity around child health and survival, and it's worsened by these contextual factors that I've talked about. And we have the knowledge and tools, and if we had the political will, we could do a lot. We could do a lot by investing early, investing equitably, and investing smartly. And we need to do this for the first 2 decades of life and beyond as possible. And we need to do it now. And we need to do it for children everywhere. So I recognize that today in Edmonton, I'm speaking to you in the context of low and middle income countries, but I'm not. I'm also talking to you about children in Canada. I'm talking to you about the needs of Indigenous population. I'm talking about needs of children who are children of immigrants and they live in relatively impoverished circumstances in our bigger cities. And that's why it's important in this global health fair and conference that you recognize that global health is not something that exists far out in low and middle income countries. Global health is everywhere. And in the definition coined by my friend Jeff Copeland, global health is an area of study, research, and practice that places a priority on improving health and achieving health equity for all people worldwide. Thank you very much for your attention. And if there's an opportunity, I'll be happy to answer questions.